25 minutes.
Thank you, Dr. Saad. I'd like to thank SSBMT for inviting me to present in this Congress. I will talk about stem cell transplant for sickle cell disease, and the next speaker, Dr. Juzou, he will talk about the thalassemia. This is my disclosure. I will try to summarize in this presentation our transplant activity in our center, especially for adult, and some of the challenges that we are facing and how to overcome them. And I will present selected abstract from the latest EBMT 2023. I will start with the case presentation. This is a 19-year-old male referred to us for transplant. He had history of stroke 5 years before he came to us. He was treated with monthly transfusion and hydroxyurea. And his MRI brain showed multiple old infarct and moya disease. So continuing with chronic transfusion, the risk of another stroke is around 11%, and if there is no intervention, the risk is more than 60%. So this was very clear indication to take him for transplant. We find a full match related or sibling donor, his brother, who was healthy. He underwent the transplant in 2015. If you see the first visit, his hemoglobin was 98, and the last visit, 7 years post-transplant, his hemoglobin is 152. His hemoglobin S now is 0, despite having only 87% chimerism or mixed chimerism, and he has no hemolytic marker. He did not require any transfusion, no admissions, no GVHD. He finished his school, then he finished the university study, and we think he is cured now. Sickle cell disease is a very common monogenic disease. More than 300,000 babies born every year worldwide. It is common in Saudi Arabia. We have more than 80,000 patients. For Ministry of Health website, there is the rate of carrier state is 4.2%, and disease state is 0.26%. In some areas like Eastern Province, the carrier state is up to 17%, and the disease is 1.2%. It was estimated from one of local studies around 10,000 of the patients they need transplant based only on 3 indications, which is stroke, recurrent acute chest syndrome, and VOCs. This is a very big load of patients who need the transplant. Sickle cell disease and mortality is a known problem for a long time, and we know that sickle cell patient previous decades, they lived until the 3rd decade, but now with improvement in therapies, we see some sicklers living to the 4th decade, and rarely we see patients in the 5th or 6th decade, especially with the new modalities of the treatment, and hopefully this curve will go further. So their survival is lower than normal general population. In one of the studies from USA, 2 centers, the median survival for sickle cell and S-beta null thalassemia is around 48. The median survival is around 48 years. And for sickle cell C and S-beta plus is 54.7 years. So there's also poor quality of life in sickle cell disease. This was a study with the questionnaire about health-related quality. Given to different types of diseases, including cancer patient, thalassemia, sickle cell disease, and compared them to the healthy population. So in the left side, we see the pediatric population, and the right side is the adult population. You see the sickle cell disease, their score for health-related quality of life is almost similar to the cancer patient, and also for adult patient, it's less. The health-related quality of life score was even less than cancer patient. The cost of the treatment for sickle cell disease is very high. This is a study from USA. The lifetime sickle cell disease attributable cost is very high. For a female patient is $1.5 million, and for male is $1.7 million. And out-of-pocket cost is $42,000 for female and $45,000 for female. The total economic burden on inpatient care of individual sickle cell disease patient in the United States was $811 million in 2016 alone. And we have similar number of population to the USA, so we estimate the cost of treatment here in Saudi Arabia may be similar or around that number. So the sickle cell disease is associated with lower survival, poor quality of life, high cost of therapy. Unfortunately, we don't have a very effective therapies. We have the old-fashioned treatment, transfusion, hydroxyurea, folic acid, and the new drugs like risankizumab, foxilitor, and L-glutamine. None of this is curative, and some of them just provide mild control of the disease. One of the drugs like risankizumab was negative in the phase 3 study compared to placebo. So we have to look for curative options like allogenic transplant and gene therapy. The first case treated with allogenic transplant was in USA, published in 1984, a patient with sickle cell disease who developed acute leukemia, and the patient underwent transplant from a matched sibling. So the patient was treated cured from the leukemia and from sickle cell disease. This opened the door for transplant in hemoglobinopathies, and we saw the curve of transplant over the years increasing. This is a report from CIBMTR, especially starting from 2010. The number of cases reported to the CIBMTR and which underwent transplant is increasing year by year, and we expect now even more cases will undergo transplant. The indications for transplant: patient with CNS events, end organ damage like sickle nephropathy, hepatopathy, sickle lung disease, recurrent acute chest syndrome defined by 2 attacks in the last 2 years despite on best available therapy, recurrent VOCs 2 per year requiring admission despite on best available therapy, multiple joint AVN despite on best available therapy, recurrent priapism, regular red blood cell transfusion 8 per year to reduce complications or symptoms, red cell aluminization, and poor quality of life. The outcome of transplant in children is excellent and improving over time. In some reports, it's almost approaching 100% overall survival. And as you see here, multiple studies, the collective number is more than 94% overall survival, and disease-free survival is more than 91%. Our colleagues here in this hospital in pediatric, they compared the outcome of sickle cell disease patients who underwent transplant using myeloablative conditioning compared to the reduced intensity conditioning. As you see, the curve for myeloablative conditioning was the survival, event-free survival was 100%, but the reduced intensity was associated with significant lower event-free survival with higher risk of relapses. The concerns using myeloablative conditioning is risk of premature gonadal failure, amenorrhea, and infertility. So you are curing the pediatric patients, and when they grow up, they have this major problem. And this is what we see when these patients refer to the adult long-term follow-up clinic, and the risk of long-term transplant complications. This is a registry-based study from different registries, 1,000 patients, majority pediatric. The outcome based on the stem cell source was, as you see, cord blood was high, followed by bone marrow, and then the peripheral blood. But the overall survival for children in this large study was 95%, and for adult is 81%. So the survival for transplant in adult is lower than children's. And the reason for this worse outcome in adult is multiple, which include organs dysfunction and reduced tolerance to myeloablative conditioning, multiple transfusions and higher risk of graft failure, iron overload, impaired immunity, increased risk of CNS event. So different centers start to look for different protocols, especially using reduced intensity conditioning and non-myeloablative conditioning in adult patients. This protocol, which was developed by NIH, it's a chemotherapy-free regimen. Basically, there is the conditioning is alemtuzumab, which is a monoclonal antibody against CD52 on T cell and B cells, and plus total body irradiation 300 centigrade. And the GVHD prophylaxis was sirolimus. And the outcome of this protocol was reported in different publications, but overall survival 94% and disease-free survival 88.5%. And this was also done in other centers and published in multiple publications from different centers. And our publication in collaboration with NIH and Chicago, 110 patients, almost resulted in similar outcome, 94% overall survival and 87% event-free survival. The fourth study is a pediatric population, which has also a similar outcome. One of the things in this protocol, all patients have mixed lymphoid chimerism, as you see in the curves on the left side. For our group, we have this abstract in ASH in 2020. So event-free survival is 87% and overall survival 97%. When we compared our transplant using this protocol for adult to pediatric group in our hospital using myeloablative conditioning, as you see, the event-free survival and overall survival for pediatric group is 100%. But if you, for overall survival, we improved the curve compared to the previous publication from the large registry-based study that it was 81% for adult. Now we improved it to 97%. This is another case that we did for him, the transplant, 43-year male patient with sickle cell anemia, and he had sickle nephropathy and end-stage renal disease. He was treated with transfusion hydroxyurea, and he was in peritoneal dialysis. We did transplant for him in June 2021 from a match-related donor carrier, his sibling. And as you see, his hemoglobin pre-transplant was 56 gram per liter, and post-transplant it was 147 gram per liter. His creatinine was high. So we have special modifications in this protocol to accommodate patient with end-stage renal disease. He underwent kidney transplant 18 months post bone marrow transplant, and it was successful double organ transplant, and now his creatinine, as you see, is normal. And we have this publication in last EBMT as abstract showing the feasibility of doing a transplant for patients with end-stage organ damage like kidney failure and liver cirrhosis, child A and child B. With, as you see, the event-free survival was 100% and overall survival was 100%. 6 patients with sickle hepatopathy and 6 patients with sickle nephropathy. Now we are doing this transplant as outpatient mainly, with giving prophylactic antifungal, antiviral, anti-BCG, and ciprofloxacin. We did 39 patients as outpatient almost for the last 8 months. 8 patients did not require admission, 31 patients required admission, but there was no ICU admission. The median days of admission was less at 21 days. 3 patients developed febrile neutropenia, and the platelet and neutrophil engraftment was not affected by doing this as outpatient. So this allows us to do more transplant of patients with this protocol, and it will be improve the quality of life for this patient when they underwent transplant as outpatient. So in our experience, the advantages of this protocol, it is tolerable, no age restrictions, no GVHD, can be done in high-risk patient, and it preserves fertility. So from the total group we did so far 250 patients, 21 had successful pregnancies. Some of them they have multiple pregnancies, and 1 had twin. It can be done as outpatient. Disadvantage, graft failure is 13%. Patient may need to continue on sirolimus. In our previous publication, 17% of patients at 5 years they continue on sirolimus, and the last follow-up for us is only 4% they are on sirolimus. Mixed chimerism, majority of patients, and there are studies showing now linking this mixed chimerism in hemoglobinopathies post-transplant with increased risk of clonal hematopoiesis and myeloid malignancy. In our experience, we did 251 patients, 204 patients, they are more than 1 year post-transplant. 75% of them, they have mixed chimerism with median follow-up 39 months. Some patients, they reach 7 years. None develop this clonal hematopoiesis and none develop myeloid malignancies. We are not checking for it, but with follow-up, we did not have any patient who developed this complication. So the graft failure is the major problem with this using like non-myeloablative or reduced intensity conditioning, and not only that, it's associated with lower survival. This is a publication from last ASH from our group, by our fellow Dr. Isra. So those who has graft failure, they have lower survival, 74%, compared to those with no graft failure. And when we look to the factors that increase the risk of graft failure, ABO incompatibility, the minor ABO incompatibility was associated with increased risk of graft failure. Major ABO incompatibility was not, actually it was predictive. 16 patients with major ABO incompatibility, none of them developed graft failure. Alloimmunization was not associated with the increased risk of graft failure. However, RBC antibodies against donor RBC antigen was associated with graft failure. RH mismatch, CD34 dose, CD3 dose was not increasing the risk of graft failure. And the multivariate analysis, the only factor that was associated with graft failure is RBC alloantibodies against donor RBCs and minor ABO incompatibility. Major ABO incompatibility was protective, because in this group we are using rituximab before the transplant. So strategies to reduce the risk of graft failure: to select the best donor with the full HLA match, ABO match, and avoid a donor who has antigen and the recipient has antibody against this antigen. Intensification of immunosuppression before conditioning, and I will show abstract from EBMT about this. Intensification of conditioning regimen using BTCY as GVHT prophylaxis or Hablo protocol for match-related donor. Rescue immunosuppression if graft chimerism drop, and use of hydroxyurea and hypertransfusion pre-transplant. This is what we are doing with Hablo transplant. So our protocol to reduce the risk of graft failure, as I mentioned, to select the best donor who is ABO match. If patient has RBC alloantibodies directed against donor RBC antigen, now we try to look for another donor. If there is no other donor, we do desensitization with rituximab, steroid, and plasmapheresis. If there is major ABO incompatibility, we give rituximab and 3 sessions of plasmapheresis, and we make sure the azoagglutinin titer is less than 32. Other factors to consider: the pre-transplant hydroxyurea, high dose of CD34. In this protocol, we use mega dose of CD34 and optimum cellular mass level post-transplant. This is from EBMT last meeting from Netherlands. They are using the same protocol, but they give in this protocol preconditioning like immunosuppression with azathioprine and hydroxyurea for 3 months. And as you see in the graph there, the level of T-cell chimerism improved significantly, reaching 80%. The event-free survival is improved also. In our experience, it was 87%. Here, it was 94%. So, by giving the immunosuppression before conditioning regimen may reduce the risk of graft failure. Another publication from the EBMT. This is from Indian group. They use this. They call it Apollo protocol for match. This is a pediatric group from match-related donor or unrelated donor. So they used the Hablo protocol, flow-cy TBI, plus they added thiotiba and ATG and BTCY as GVHT prophylaxis plus sirolimus. But they had the same concept of immunosuppression preconditioning with azathioprine and hydroxyurea for 3 months. And they also here they use the peripheral blood, not the bone marrow harvest. And as you see in the Kaplan-Meier curve, there is improvement in overall survival and reduced risk of graft failure. Both reaching 95%. Another abstract from the EBMT, this is from our colleague in King Faisal Hospital here. They compared their outcome for adult patients between myeloablative conditioning and Hablo identical transplant. So in the myeloablative conditioning, they give Lobio4 plus ATG with GVHT prophylaxis, MTX plus calcineurin inhibitors, and the Hablo protocol is the protocol that we use in the Vanderbilt consortium, which is flow-cy TBI plus thiotiba ATG pre-transplant and BTCY, and the source of the stem cells is the bone marrow harvest. They have shown the 3-year overall survival for match sibling donor is 95.1%. There was no graft failure. So by giving myeloablative conditioning, you can reduce the risk of graft failure. But however, there is still risk of 5% mortality, and mostly come from complications from myeloablative conditioning. And the haplo transplant, although small number and short follow-up, it was 100% overall survival. So the concept here, you can use myeloablative conditioning in adult, but there is an increased risk of complication, morbidity, and mortality. This was also abstract from the last EBMT from different centers from Netherlands and Vanderbilt and the group of Dr. Jisoo, who is here with us. So they do the transplant and they follow the chimerism. If there is full lymphoid chimerism and with time there is drop in the lymphoid chimerism, they give immunosuppression with alemtuzumab, 1 mg per kg. And there was 6 patients, 2 haplo non-myeloablative, 3 match-related non-myeloablative, and 1 match-related myeloablative. 5 patients responded to this immunosuppression with alemtuzumab. There was no increase of viral infection. This approach needs to be explored in large cohort. So now we'll talk about the other challenge, which is availability of donors. The finding of donor from this is multiple studies from Western world, 18% to find a matched sibling donor, and match unrelated donor is less than 18%, and haploidentical is universal availability. In our centers, for sickle cell disease, 57% we were able to find matched sibling donor for them. So if you don't have a matched sibling donor or match related donor, the next choice, like in malignant indication, you go for match unrelated donor. Now, there are multiple studies showing the effect of the outcome of match unrelated donor in sickle cell disease. I will just highlight this publication from Dr. Shinoy. It is BMT CTN study, phase 2 study, flumil alemtuzumab. As you see, the risk of graft failure was 10%, overall survival 79%, and event-free survival 69%. This is a children group, and this is a very low outcome. With acute GVHD 28%, chronic GVHD 62%, 38% of them is extensive, and transplant-related mortality 28%. So after this publication, many of the centers, they avoid the match unrelated donor for sickle cell disease, unless in clinical trial. The other option is the haploidentical transplant. So you have the two concepts of reducing the risk of graft failure and GVHD either by giving PTCY or by ex vivo T cell depletion. I'll just talk about one, for the sake of time, one publication, which is our international collaborative or consortium, Vanderbilt consortium, which is using the haploidentical platform, Flow-Cy TBI, adding to it Thiotiba and ATG with the source of stem cell bone marrow, and BTCY plus MMF and sirolimus at the GVHD prophylaxis. The initial publication was in 2018 by Dr. Jisoo on 18 patients. Overall survival was 100%, and event-free survival was more than 90%. When more studies joined more centers, they joined this consortium, including our center and King Faisal here in Riyadh, with enrollment of more patients, 80 patients, as you see in the table. There was 50% for children and 50% adult. The graft failure for adult was 0%. So this protocol reduced the risk of graft failure in adult, but in children it was 25%. So this was not enough to reduce the risk of graft failure. And the risk of mortality was 5% in both groups. So for children, pediatric group in this consortium, there is more modification by giving hydroxyurea and hypertransfusion 2 months before transplant, and this hopefully may reduce the risk of graft failure. So in conclusion, there is global increase in awareness and utilization of transplant in sickle cell disease, especially with improved outcome of transplant lately. Transplant at young age with match-related donor using myeloablative conditioning provide the best result. Acceptable outcome in adult patients using RIC or non-myeloablative regimens. Graft failure is a major challenge. Strategies to mitigate this risk is proposed. Haploidentical donor transplant is the next donor of choice based on the current evidence. Thank you very much.